Hey guys, it's your Mblex Study Buddy again. I wanted to finish up from my first video. I apologize, my iPad ran out of storage. But to finish that up, I was just going to say that you should probably just save the photos and just use them for your own benefit and for your own curiosity to see your own techniques and how they work. Um, I don't know too many people that actually use that as a means of treatment for the other people. But anyway, we're moving into, I'm still in basic clinical massage therapy, and I am on page 42. We've got some pictures here to show you what you should do with people if you're going to do photographs, and these are the things that you're going to have them do, the positions you're going to have them in whenever you take your photos, so that you can see proper alignments and other things like that. And going into the figure 2.3 and 2.4, which was on the first page, if the client has scoliosis, it is helpful to take a close-up of the back from the head to the coccyx and photograph the client bending over with arms hanging straight down to document the rotation of the rib cage. It is useful to routinely examine children and early teens in this way for scoliosis. The presence of a rib hump, which is evidence of the vertebral rotation or idiopathic scoliosis, and parents should be encouraged to consult the child's physician. Some clients may prefer not to be photographed, or some therapists may choose not to use this technique. In these cases, the therapist can still observe the client in all of the above positions. Some additional positions and movements that are helpful for observation but not need to be photographed, including bending to side from the waist and bending backward with the arms stretched over the head. The goal of asking the client to assume these various positions and stances is to observe the dynamic structure of the body. Even when the client is in normal resting position, we are actually observing muscles at work. It is just like a bird's leg, and they are always working. Even in sleep, to keep it on the perch, our muscles must always respond to gravity. The ideal posture of a person standing at rest demands minimal muscle activity to maintain an upright posture. The ideal functioning of the body in a person in motion uses minimal muscle activity to accomplish any task, and will use larger and stronger rather than smaller and weaker muscles whenever possible. The body at rest. When we observe a client standing at rest, we view the body in relaxation to certain planes. Although we work with these planes as lines, it's important to remember that they are planes, or we will be deceived. Look at the client from the front or the sagittal plane. The midline that begins at a point midway between the feet. Since that stance is the resting point for the weight and passes through the pubic symphysis, the navel and the xiphoid process, the manubrium and the center of the chin and the nose. Note that any deviation from that line. Also observe the kneecaps and the feet. Do they point forward, or do either of them deviate inwardly or outwardly? Viewing the client from behind the sagittal plane is a line that again begins midway between the feet and passes through the gluteal cleft and the coccyx, straight up through the spinal column and through the middle of the head. Comparing these two views can teach you how to think in planes rather than in lines. In other words, how you see a client in three-dimensional rather than two-dimensional view is often the upper body of the client appears to lean to one side when viewed from the front, but lean to the opposite side when viewed from behind. This illusion is created by seeing lines rather than planes. In reality, the client's upper body is slightly rotated, placing the landmarks on the torso to one side of the midline in front and to the other side in back. Viewing the client from each side, the frontal plane, figure 2.4, is a line passing just in front of the ankle through the knees. The greater trochanter, the glenohumeral joint of the shoulder, and the ear. Again, any note of the deviation of this line, you should make note of any deviation from this line. Therapists who do not take photographs or use a computer may find a plumb line helpful in making these observations. A long string weighted at one end or a 2 or 3 ounce fishing sinker works pretty well. Can suspend in place where the client can stand behind it to be observed. The plumb line gives a therapist visual reference point for observing alignment deviations in figure 2.7. So we have these lines right here. And you can see on the bottom here where whenever someone bends over, you can see the deviation in the back for the indication for scoliosis. You want to ask, are the shoulders level? Are the shoulders rotated medially and pulled forward in a slump? Is the pelvis tilted to one side or the other, or is the pelvis tilted forward? You can make these same observations with the client's arms stretched overhead with the wrists crossed to see whether the shoulders yield evenly on both sides. Notice various body landmarks in a stretch. Do the deviations you already may have observed correct or reverse themselves or worsen? The breast or nipples move with the tissue overlying the ribcage in position of the breast is normally visible even if covered. So how do they change in relation to each other over a stretch? You may want to make notes of your observations, particularly if you do not take photographs. And remember that no individual view is sufficient to yield significant information. Each view is merely one piece of a three-dimensional puzzle. Merely viewing the body at rest is insufficient to give a full assessment of the client's body, and the more pieces of the puzzle must be considered. The body in motion. The first step is assessing the body in motion is to observe the client's gait from the back to the front and to the side. Do the legs swing straight forward or do they deviate from that course? Even slightly. Along the way, notice individual aspects of the legs. Is there medial pulling motion or are they on the inner thigh? Did the kneecaps always point forward? Did the feet point straight ahead through the swinging of the leg? Viewed from behind, or does the pelvis tilt from side to side or swivel with the gait? Ask the client to bend over backwards with arms stretched over the head. Does the body form with graceful arch, or what happens to the lumbar? And then you can see on this page what they're talking about. I think we've only got a few more pages of this. Alright, so here's this. You can show the different ways to see the posture and alignment. Does the head go backward with the rest of the body or does it remain upright? Is the client able to stay balanced in this position? Ask the client to bend the torso to the left and to the right, with the arms resting at the sides. Notice any differences in flexibility between the two sides. Sitting behind the standing client, place your hands on the ilium with your thumbs pressing into the dimples at the posterior superior iliac spines or the PSIS. Ask the client to bend forward and follow the PSIS with your thumbs. Do they remain even or does one move upward and the other or ahead of the other? In other words, does the sacrum rotate during forward bending? Make notes of the deviation during movement just as you did for the body at rest. These findings contribute to the solution of the puzzle. Measurements. For many therapists, the observations described above will suffice for any analysis of the overall alignment of the body. Others, however, may want to take specific measurements, either document change for the client's records or medical reports, or for formal or informal clinical research. Such measurements are easy to take depending upon the measurement tools used. Range of motion. The complete examination includes measuring the range of motion, or the ROM, of the hips, shoulders, or of the hips and shoulders. These measurements are normally taken with a geniometer. Okay. A widely available and fairly inexpensive instrument for measuring angles of joints. These measurements should be made with the client lying supine. Okay, so here's some images with, I don't know if you can really see that all that well. To determine the range of motion of the hip, stand at the side of the client and at the hip and raise the client's leg by holding it by the calf, fully extending until the knee attempts to bend slightly to accommodate the stretch of the hamstrings. Measure the angle of the joint in relation to the horizontal plane. To determine the range of motion of the shoulder should not be abducted, or should be abducted at least 90 degrees and the elbow flexed at 90 degrees, so that the fingers point at the ceiling, standing beside the client at the level of the shoulders. Place your hand nearest the head on the client shoulder with your fingers lying over the superior border of the scapula. Rotate the forearm forward toward the table, medial rotation of the shoulder until it lies flat or until movement is felt with the scapula. If the forearm does not lie flat without movement of the scapula, the angle should be measured and noted. Then rotate the arm upward, lateral rotation of the shoulder until it lies flat or movement is felt on the scapula. Again, measurement note, feeling for movement in the scapula is necessary to determine actual glenohumeral rotation, rather than rotation that may be accommodated by movement of the scapula. Body alignment. The most useful device for measuring body alignment is the inclinometer, which is the equivalent of the carpenter's spirit level adapted for bodywork purposes. The inclinometer indicates the relationship of a given line, such as the line of the hips or shoulders to the horizontal plane. One of the most useful devices on the market for this purpose is the palm, the palpation meter made by Performance Attainment Associates, St. Paul, MN, and the palm is a combination of the inclinometer, words really tripping me up, caliper, and the special slide rule. The caliper tips are held with the finger against any 2 points of the body. The gauges show the distance between the 2 points and the angle of the deviation of the line between the two of them from the horizontal plane. Using these two figures, the slide rule device calculates the exact height difference in inches or centimeters between 2 points. This system allows the relationship of any 2 points on the body to be determined with a high degree of specificity. I can't say that word. I actually cannot say that word. With specificity. Okay. That's not actually how you're supposed to say it, but I think you guys get what I'm trying to say. I'm sorry. In reality, the angle is the most important piece of information for the therapist. Since the height differential will vary according to the size of the client, even at the same angle, the larger client who has the same angle of the deviation as the smaller client will have a greater height differential. Since the points being measured are further apart, the height differential of use primarily to give the client in the area in the idea of the amount of deviation. The primary advantage of palm lies in the ability of the therapist to use the fingertips as the caliper tips, hence the name palpation meter. Sorry guys, I gotta highlight a few of these things. It's gonna take me a minute I'm gonna have to figure out how to say that word. And of course, you guys, I know it might be completely monotone and really super boring to listen to me attempt to read this, but I really do hope that this does help for those of you who have a hard time being able to sit down for long periods of time and read. I'm sort of that way, but I'm hoping that by doing this, it also helps me be able to study in certain areas, because this is actually very, very, very valuable information. And I also want to point out that there is a YouTube video that shows you all the different points that you can touch and look at as far as a visual assessment. It's a really good video, and it's only about 8 minutes long, so I will attempt to find the link and post it with this video. I don't know if YouTube allows me to do that or not, but I'll attempt it. And if nothing else, I'll post it in the Mblex Study Buddy group. Or, I'm sorry, the Mblex, yeah, I think it is the Mblex Study group on Facebook. So I will attempt to do that. Testing areas specific to the complaint. By carefully noting the analyzing the type of location or discomfort produced by the following combination of tests, the therapist can gain valuable information about the likely nature of the dysfunction. Therefore, the next step in the assessment is to test the areas specific to the complaint. First, determine the position that best suits this purpose. Usually the client stands to have the hip joint tested, sits to have the shoulder joint tested, and sits and stands for testing of the knees. More of the area may be accessible to the client when standing or sitting when the client is lying down. In these positions, you can easily palpate the tissue while the client moves the joint. The joint should be tested both actively and passively. The client moves through the joint through its full range of motion, reporting any pain, discomfort, or barriers to the movement. In passive testing, the therapist carefully moves the joint through the same range, with the client instructed to relax the limb and give control to the therapist. The client should be asked to describe any differences in feeling between active and passive movement. Then, in whatever position is suitable, the therapist tests the active movement of the joint against resistance. The client is instructed to move the limb in a particular direction while the therapist rests the motion or report any feelings associated with that comfort. So here they have like a really weird like contraption thing. I don't want you to see this. So they're showing you the collarbone, the rib cage, the iliac crest. They're showing you a lot of those different points that you can test to see where some differences and variations maybe. And then over here we have a little examination chart that you can use for your own helpful guidance to see where everything is at. And that's, I'm guessing that this little instrument will be able to show you the variations easily as far as which one's up and down and all that. The next thing that we have is the breathing examination, and then we have manual palpatory examination, and then let's see, we got 3. And we have special population. So yay, we're getting there. An essential element in assessment is examining the client's breathing technique. Many, if not most, older children have and adults have developed the habit of paradoxical breathing, expanding and raising the upper rib cage while keeping the abdomen and lower rib cage constricted. Paradoxical breathing is detrimental to muscle health and posture for a number of reasons. Inappropriate use of neck and shoulder muscles in breathing causes chronic tightness in those areas, which can result in forward positioning of the head and development of the trigger points or nerve entrapment. Tight chest muscles pull the shoulders forward and rotate the arms internally. Inflexibility in the muscles of the chest and abdomen can pull the anterior cage forward and down, exaggerating a thoracic kyphosis, which is the curve on the top, kyphosis. You got lordosis for the lumbar lordosis. You got the top part, that's kyphosis. Anyway, that's how I remembered it. Finally, a good diaphragmatic breathing techniques use the full capacity of the lungs, optimize the exchange of blood gases, and enhance relaxation. Therefore, if your examination indicates that your client breathes paradoxally, it will be important to incorporate training in diaphragmatic breathing technique. The complete procedure for assessment or assessing the teaching breathing will be found in chapter 4. So when we get there, we're in chapter 2. When we get there, we'll go back to it. The manual palpatory examination. This one is probably one that everyone is going to be using most in their practice, because that's kind of what we do. But just in case we have some overachievers, you can use all of these other techniques as well. I'm joking. Whatever works for you. This part of the examination brings in with the client sitting or standing. According to the circumstances throughout the examination, the client will sit, stand, or lie successfully, supine or prone on the table in whichever order the therapist finds most useful and efficient. It is often best to perform the palpatory examination in the area of complaint before or during the specific testing described above. If the client chooses to be examined and treated only for relief in the specific complaint area, then you should limit your palpatory examination to those areas likely to be contributing to it. In any case, finding and treating the immediate source of pain or dysfunction is one of your primary objectives. You may find it useful to refer to Appendix C, which is muscles by pain referral zones. We're going to have to look at that. In choosing the range of muscles to examine to determine the source of the client's pain. Therefore, each muscle description in Part 2 of this volume presents a list of other muscles to examine. Do not stop with a single positive finding. A trigger point that reproduces the client's pain may not be the sole source of the problem. Thorough exploration of the muscles in a particular body region will increase your accuracy, efficiency, and effectiveness of your treatment. Broadly speaking, the palpatory examination has two parts. 1, the general assessment of the tissues in each area, and 2, the precise palpation for taut bands in the muscles and tender or trigger points. Both parts are continuous and contiguous with therapy. As you treat, you examine in the initial evaluation. The information you gain throughout palpation is an essential adjunct to information you obtain through observations and measurements. The palpatory examination, it begins again with observation. Look at the area you are about to examine. Notice its color, especially in comparison with other areas of the body. Is it pale or pasty? Does it have the angry redness or inflammation, or does it appear gently flushed, as healthy tissue should be, without radical contrast to other areas? Begin with a broad, gentle general stroke. Lay your hand on the area you are examining and just let it rest there for a moment. Feel the temperature of the area. Is it cold? Is it cool, hot, warm? Does it feel damp or sticky? Is it unpleasantly dry? Healthy skin should have a subtly moist feeling to it without dryness, dampness, or stickiness. Allow your hands to press a bit deeper and move the skin around over the underlying layers. Does it seem stuck, or does it seem loose, or does it feel firm but mobile, as if connected to the layers underneath? It is not adhered to them. Draw your fingers across the skin, noting where there is drag in the tissue that impedes your motion. Such palpable phenomena at levels of the epidermis, dermis, or the superficial fascia often reflect the underlying tissue dysfunction. Note any marked differences in an area. Differences in temperature and moisture can be signs of sympathetic of sympathetic nervous system activity in response to problems in the underlying tissue. Fascial tightness and tissue congestion are usually signs of myofascial problem. Remember also the classic signs of local inflammation: heat, redness, pain, and swelling. This combination is a contraindication for local massage work. At this point, you can move deeper still and begin to use your fingers and thumbs in whatever sort of palpation suits the shape of the tissue. You are feeling the muscle tissue and you want to learn whether it is flabby or firm or hand or hard, not hand, hard or contracted. Move your hands, palpating different parts of the muscle to feel for taut bands and knots in the tissue. Ask the client to let you know what areas are tender, ticklish, numb, or feel in any way strange. Also be aware of the client's nonverbal responses and cues. The clients will not always be very verbal, and they will not always communicate to you about everything they feel. Be alert to wincing or making facial